Good evening. This is Dr. John Bennett broadcasting from Miami, Florida. Tonight we have the honor of having Dr. Martin Olsen from East Tennessee. Martin has done a good bit of work with a simulator called Chloe, um, and he also uses Google Glass as a teaching adjunct along with using Chloe, and he's going to explain all about it. So welcome, Martin. It's all yours.
Well, thank you very much, John. It's good to have a chance to chat and share my work. You see on the cover slide here, there's a picture of Chloe in the simulator. She's on the lower left. She's got her Google Glass on. And then on the upper right, you see a picture of Chloe having a surgical procedure done. And the purpose of this simulator is multifold. So number one, we can teach people just how to operate. She has a blood supply. It's a physiologic blood supply. And that means that if the teacher wants the blood pressure to be 60/0 and a patient in shock, then that's what it is, and the pulse is 140. Or if they want the simulator to have a blood pressure of 120/80 with a pulse of 70, that's what she has. And so the learners have a chance to operate in a controlled environment. We can stress them in a way that you can't really stress them with a live patient. We can force them to make mistakes, and they get to learn from their own mistakes. So that's one of the things that we can do with Chloe for teaching. Now, she also has a patient safety focus because we could do patient safety drills with her. So, for example, she could come into the emergency room, maybe even brought in by an ambulance. She has a diagnosis of ruptured ectopic pregnancy. We see how long it takes the ER docs to make the diagnosis. We see how long it takes her to go to the operating room. We see how long it takes the anesthesia to arrive, the surgeons, gynecologists to arrive and do the procedure. So that would be an example of her patient safety capabilities. I do have to mention my conflict of interest. I'm a consultant for Gumard Scientific, who makes that simulator, and I'm a co-holder of the patent for her, so one of these days I might make $1 or $2 from sales of Chloe.
All right, good luck.
That's right. So just to mention some of the simulation functions, transferring knowledge from seasoned clinicians to learners, allowing learners to practice their diagnostic skills, the surgical skills training, the drill training, and the human factors and team training. And I think that's very, very important for a simulation team because they can teach learners things that the learners really can't learn in front of the patient. So you can't do the drunk attending in front of a real patient. You've got to have a scenario where the learners can intervene and decide how to deal with an impaired colleague. And you can do that in a simulation lab, not in a patient care environment. For those of us that are medical educators, we have these things called competencies that the governing bodies of academic medicine say we must teach our learners, and these are the 6 competencies for residents. And my saying is, you've got a competency, I've got a scenario, and so we can go over any of these competencies, usually even more than one, with a particular 20 to 30-minute simulation exercise. And there are many types of simulation, and we're spending most of our time in this discussion with high-fidelity simulation, but I did want to just review some of the others. So animal tissue, we've done that for a long time. Learning how to suture on chicken meat is one thing that we can do to teach people what tissue feels like. Low-fidelity simulation in obstetrics actually goes back hundreds of years. So they would take pelvic bones from deceased women, they'd put some leather on it, and they'd use that to teach midwives how to deliver babies. High fidelity, these simulators have heart sounds, lung sounds, eyes that blink, and they really challenge the learners in their interactions with the simulator. Virtual reality is a computer program which allows people to operate on the computer. They'll use special instruments. The computer will read their skill level, their technique level, and provide feedback on their speed, their dexterity.
Are you changing screen? Excuse me, Martin. Are you changing screens because it's not changing?
Yes, I am actually. We're now on like the 5th slide.
Okay. Could apparently it's not working correctly. Could you try it again, please? Put the slide you want to switch because it's just the original slide is still up there.
Well, right now I'm on one called Low Fidelity Simulations. I'm about 5 slides into it.
Oh boy. Well, what can we do here? Maybe can you go directly to that slide again and share that screen? Get off the screen share and go back on. Maybe that'll help a little bit. The screen sharing is kind of funky sometimes.
Okay.
You'll get it.
So I'm ending the show.
No. You're just going to the 5th slide direct.
Well, right now, do you see a screen that has a PowerPoint?
Yes, but it's the first PowerPoint.
Still just the first slide.
Yeah, it's the first slide.
Yeah, back on the overview slide.
Right. If you can, I can see your cursor moving around.
Okay.
Now you're back on your screen, so just try to share it again.
All right. So you're seeing me now.
Yeah.
Okay.
So share the screen again.
All right. So back to the screen one.
Right.
Screen share. But I have to bring this one back up first, right?
Yeah, if you could, the 5th slide that you had, go to the screen share and pick that one.
Okay, so here we go.
Google does, it gets temperamental.
Well, that happens, yes. All right, do you now see a PowerPoint?
It's the first PowerPoint again.
So what's on my screen is
innovation in medical education. The first slide.
Okay. Now do you see conflict of interest?
Conflict of interest slide.
All right. And then this was the simulation functions.
It's working out. But
simulation. All right.
Right, it's working out. Great.
Well, if that's the worst thing that happens, we'll have a pretty good discussion, won't we?
Okay.
All right, where you see a picture of some plastic patients.
I'm seeing the types of simulation now, right now.
It should say low fidelity simulation.
Oh boy. I'm sorry about this, Martin.
Well, I think I know what we're going to do here. I think it doesn't like the whole screen filled with a...
Yeah, okay. Okay, whatever.
Click on... Okay, still back on that same slide? Do you have...
I see the picture of low fidelity simulation.
We'll just stick with this screen then, and people just look closely at the screen, I guess.
Okay.
So this is an example of a very inexpensive simulator, and I've used these types of simulators in third world countries to teach things like shoulder dystocia, which is where the baby is stuck in the birth canal, or postpartum hemorrhage, or breech delivery where the baby's born with its butt first as opposed to its head first. This simulator works well for that. And it's low fidelity, and it's been used to train lots of folks and save lots of fetuses and mothers' lives. And then moving up just a little bit in fidelity, this is a birthing simulator with a motor in it, and it pushes the baby out. It doesn't do a whole lot else besides that, but that's another step up and another step in realism. We have this concept in simulation called suspension of disbelief, and with that concept, the more real you can make it, the more the person tends to act like they'd act in a real scenario, in a real situation. So once they're seasoned in a simulation lab, pretty soon they act pretty much like they'd act in a real patient crisis.
I didn't expect this. That's good. I didn't expect the OB part.
This is an example of a high fidelity simulator, and this happens to be the Chloe prototype. Okay. And so you can see she had one resident's checking her pulse, because yes, she does have real pulses. One resident's listening to her heart. Yes, she has heart sounds. And so as you increase your cost and your maintenance, you also increase your chance to teach residents different things. Mm-hmm. And this is an example of Chloe having her abdomen incised and cut into. So she does have the 5 different layers that a human abdomen has. Mm-hmm. And this is the uterine assembly. So this one happens to have right up here, that's an ectopic pregnancy. And then this over here, which is blown up here, is a dermoid cyst. A dermoid cyst is teratoma is another term for it, and it has lots of different tissues such as hair and fat and calcium as a part of it. It is not a malignancy usually, but it is a neoplasm. Uh-huh. And this is an example of the ectopic pregnancy actively bleeding. So for a simulation experience, there are actually 3 rooms that are important for a simulation lab. So I call this the action room. So you can see here's a patient, Chloe, a simulated patient undergoing a laparoscopic procedure. Senior resident here, junior resident here. The screen they're looking at is actually out of our view. It's up here. And they're up in a simulated operating room doing a surgical procedure. And then this is the control room. So you can see there's glass here, and we're looking through the windows. So if the patient's awake, this actress will speak for the patient. So they'll ask questions like, when was your last menstrual period? And she'll say 6 weeks ago, and then they better start thinking about whether she might be pregnant.
Okay.
As they make the patient healthy, we can control the patient's vital signs. So if everything's going well, the vital signs stay stable. And then as the situation changes, we make the vital signs get worse and decrease the oxygen saturation from this control room, and then the residents have to react to that.
Mm-hmm.
And then this is the debrief room where we talk about what we learned. And a good scenario, the time in the debrief room may be at least double what was spent in the action room. And the thought being with that the residents and the students need a chance to process their information, discuss what they learned, figure out on their own how much they can do better the next time, what they did right, what they need to work on. And part of the process of debriefing is that they're supposed to figure it out. It's not that the instructor tells them what they did, what they didn't do. They're supposed to figure it out.
Okay.
So what we've added is Google Glass, and all your listeners are probably going to be fairly familiar with Google Glass, John, or do I need to describe it briefly?
No, I think most people understand what it is. Maybe just its role in teaching by simulation, probably.
That'll be the next slide then. We put it on different places. So there's 4 ways that we've used Google Glass. Eyes of the patient is my favorite, and that's what we're going to show the video of. But basically, you stick the simulator on the page. Oh, I'm sorry, you stick the Google Glass on the simulator, and then the learners can watch from the view of this simulator how they look to a patient. So they can see themselves perhaps failing to make eye contact or perhaps failing to act in a nurturing manner. And better than me saying, hey, you might work on your eye contact, is them looking at the video and saying, ooh, I could have done better.
Okay.
My favorite is eyes of the patient. Eyes of the participant, that's where we stick it on one of the students or residents and just sort of experience the scenario through their eyes. That's, for a teacher, that's extremely helpful because the Google Glass that we did here, it's actually what I learned. Of course, we knew they were stressed, but once we started hearing these comments that we didn't hear before, I realized how stressful it is. I mean, this is real to them. They want their simulation patient to live. They want to demonstrate their abilities, and they're anxious. And I've had a much better feel for that after using the Google Glass and putting it on the participants. Eyes of the surgeon is just a way to document their surgical talent, and they can also review their own procedure, and they can decide themselves whether they are where they need to be or where they need to practice tying knots and holding scalpels and things like that. And then eyes of facilitators, when I put it on myself, and then I review my own performance after the debrief session. And what I learned doing this was I talked too much. I needed to let them talk and let them figure it out as opposed to me telling them. So there's different things to learn from all of these, and they all have a role.
Are they all live? They're all live. It's not video, correct?
Well, if you'll recall, right now we don't have live transmission of Google Glass. Now I'm trying to get live stream to work. I haven't quite got it figured out, but I'm working on it. But when they took away the Google Hangout from Glass, the only way we can have it is recording.
Right, okay.
When that comes back, right now it's just recording.
Okay.
And that, to me, that was a significant loss because we did one paper on live streaming teaching remotely, where the teacher was in a different building from the students, and the teacher was teaching the students as they wore Google Glass how to handle obstetric emergencies of breech delivery and shoulder dystocia. And the thinking was, if you're in a place like a Gaza Strip right now, and you want somebody to come and teach you, well, it's not going to happen.
Right.
But if you get Google Glass in there and somebody could teach remotely, then people can learn these skills.
It'll come back. It'll come back.
Yeah, and this live stream might work. I haven't quite got it to work. It's a little more difficult than advertised. But participant. So here's an example of the participant. She's operating. She's removing one of the dermoids that we talked about, and I think it's obvious she's enjoying the simulation experience.
Okay.
Here's a view from the glasses on the surgeon, and the surgeon's getting ready to cut away the ectopic pregnancy that has a clamp on it.
Okay.
And then here's eyes of the patient. So there's Chloe again with her glasses on. And here is our, so let's see if we can get this to play.
Okay.
Actually, for this one, let me see if I can bring it up so they can see the whole screen.
Okay.
Does it still say fire in the labor and delivery room?
Yeah, fire in the labor and delivery room.
Okay.
I hear the audio.
Noel, aren't you going fast? No, hi, I'm Robbie. How y'all doing? This is exciting. I am thrilled. Man, I'm about this woman stuff, so I'm glad you all are here.
Okay. All right. Nice to meet you, Robbie. We're the doctor from OBGYN. Noel, how are you doing? All right, Noel, we're going to take a quick exam, okay?
And John, this is a different simulator. This is Noel, a birthing simulator. So.
Is she okay? Lady okay?
We're going to take a look. We're going to examine her.
Good.
Are you comfortable with them staying in the room to do your exam? Okay. I'm just going to be videoing the whole time. You guys. All right.
Yeah, she had a really fast labor. This is my first baby. It's her fifth. And didn't you have a really fast labor last time, Noel? Like half an hour or something?
Yeah. Okay. It feels like you're actually progressed pretty far along. Okay. I'm just going to lean you back, okay? She's there. She's not on here.
Are we getting close?
I think we're getting close.
Oh, good.
Okay. Are you doing all right? So we're just going to do it one more time, okay?
Sounds real.
Well, the
Noel,
fun
can you
part's
tell me
about to
your
start.
previous pregnancies, how did you do? Any complications?
No, there are no complications.
Okay.
It was really bad.
And they came early?
Yeah.
Okay. How about with this pregnancy? Any complications?
Is it
No,
time to
that's
celebrate yet?
Okay. she's good.
Oh, good. I'm excited. I'm going to celebrate.
All right. Do you have any past medical problems?
No.
Okay. Are you on any meds?
No.
Okay. Do you have any allergies to any drugs?
No.
No. Okay. Baby's heart rate. Oh, it's react. No, I'm going to check you as well, okay? Oh, no. Yeah. No, I'm
All
sorry.
right, great. This is good. I got a cigar. Go out. I'm ready to celebrate.
Get the water in here, Mark.
Just take that outside. I'm
Stop.
sorry.
Stop. Right fire. Look at that. Oh, I'm sorry. I got fire.
Oh, no. Okay. We need to get you out of here. It's an unsafe environment, so we're going to get you out of there, okay? We're going to transport you in, sir. You're not allowed to smoke in the building. You have to take that outside. So, can we unlock? Right here. Pull this guy up. It's the lock, yeah. There we go. No. Okay. So we get you out, and she's hooked up, so I don't want to move this bed.
Hey, she need that oxygen?
We're going to get a tank to go along.
Is my baby gonna be okay?
It'll be okay, Noel. I'm sorry. I'm sorry.
We're good.
Better go fast. We gotta get out of this fire.
Okay.
Quick, run, fast.
Okay, I'm just going to sit. You're doing fine. Right on the bed with her. All right. Do you want to go here? When you feel a contraction, you give me a push, okay?
Well, I saw this thing on YouTube. They said they get stuck sometimes.
Yeah. Thanks.
Can I help?
No, sir. You can actually just stand there and hold her hand and give her some
Oh,
support.
okay.
Yeah, just talk to her. You're doing great. Good job, Noel. Your base is about out here. Good job. Are we ready? Okay, Noel, you're doing great. He's about out. All right.
They saved our baby, Noel. They saved our baby.
All
You show that
right.
baby to Noel?
Noel, here you go. I'll tell you what you're doing, but I can't tell.
All right, let's go debrief.
Okay.
We've got just about a minute
Simulation can
of
sometimes teach you things you'll
debrief.
never see again.
Okay.
Maybe never see, but fire in the operating room. So this is a subset of fire in the operating room. Fire in the operating room has the same rate roughly as wrong site surgery. So every surgery that you do when they say this is Mrs. Smith for a right oophorectomy, that's because of wrong site surgery. So fire in the OR has roughly the same rate. So it's actually something that
That's actually a lot.
that's actually yeah.
That's amazing.
And we'll go ahead and end the show, and I think we can chat now.
Okay. Very good. Very good. Very good. It looks great. It looks great. You know, I'll just start from the very beginning. Yeah, first of all, Martin, we briefly talked about you went to school in Ohio and you started your residency in Tennessee.
That's right. I did a family practice residency in Ohio, Akron, Ohio, and then I saw the light if you're an OB/GYN, or I went to the dark side if you're a family doc and moved to Chattanooga to do my second residency in OB/GYN.
Okay, and then you went directly to private practice in Johnson City?
No, actually, I'm an academician. I'm with East Tennessee State University.
Oh, okay. And will you still practice OB/GYN a little bit? Or
That's right. I'm the residency program director, and I also have a practice in outpatient gynecology.
Now, you teach, what year students do you teach?
Third year medical students, and then first, second, third, and fourth year OB/GYN residents.
Okay, so the students are undergoing that simulation in the third year of OB/GYN rotation?
That's right, yes. So these were actually brand new interns. That was July, late June before their July 1 start day, and they actually did very well for folks that had never, their MD was just a couple of weeks old.
Really? Now, how the kids like it?
Yes, they do. They like a chance to be challenged. So in medicine today, our learners, I feel, we don't give them a chance to make mistakes. So back in the old days, I made mistakes and I learned, and yes, patients did sometimes not do as well because of that environment. But now our learners are so protected by supervision that they don't get a chance to learn from their mistakes. So I try to make sure they make a few mistakes. So, for example, does she need that oxygen? Well, you notice that they said, yes, put the oxygen on the tank. Well, of course, that's not what you do if you have a fire in the room. And they figured that out later, and they learned from that mistake, and nobody got hurt by it.
Okay.
It was a good experience for them.
Well, one part I really think is useful is the difficult delivery part, because as a student or resident, when that occurs in the OR, they don't want to let you close because they've got to obviously help the baby and help the mom. You may be able to get a bird's eye view, but
right, yes.
That seems to be very valuable, and especially in countries where they don't have doctors, they have midwives who have to do a lot of deliveries. Correct?
That's correct. So yeah, I think simulation has a significant role in underserved areas.
Yeah, and they don't
not just for obstetrics, but also for the physicians. So I have made several trips to Iraq to teach physicians there, and we brought a laparoscopic simulator over there because they, at the time, were just beginning to learn laparoscopy, and now they're much better at it. But they need a chance to work on a simulator first before they work on the patient, and they seem to enjoy that process.
Iraq is the main country you've been to?
Yes, I've been to Iraq. I think it's 11 times now.
Oh, wow. All Iraq. Were you in the service? Is that why you go there?
No, I just was asked to go and said I would, and the word was out that I'd say yes, and so I got asked again and again.
Now, would you be treating the local population or local doctors? Or
Actually, we do education of the doctors, so it's very important, I think, for physicians that come in on a short-term basis to not disrupt the healthcare system that's in place. So my opinion is if doctors show up and say, hey, let's let's take care of a bunch of patients here. We've just disrupted the medical community for that area while we're there, and then it may take months for them to recover. So what we do, and our group is 2 Americans and 2 British physicians, is we come in and we say, this is how we do it. Let us tell you about it. And the British and the Americans may have different views, which is fine, because then the Iraqi or Iraqi Kurdish physicians can say, well, they've got 2 ways to do it. Let's figure out what's best for us in our environment.
Yeah.
So our goal is just to, I think, inspire them to be the best they can.
Oh, okay. Let's see. So 3rd-year students. Now, how much do the students use the glass during one aspect of the simulation, correct?
This particular scenario that you just saw was the eyes of the patient use, correct?
Okay, and
I've used it for eyes of the surgeon on residents to allow the resident to watch themselves and run the video and see what they look like, so they can sort of self-assess their skill level.
how do the students take to that? Do they like using the glass?
Interestingly, the students seem to love the glass. The residents are a little less excited about the glass than the students.
Really?
It's a smaller group with the rest, so it's some of the residents like it, some of them don't, and I think there's a little more concern sometimes that their need for improvement in certain areas might be more obvious than they'd like it to be.
Now, does it take the students a long time to? Is the learning curve pretty steep, or?
Well, I really don't give them. They don't have enough exposure to learn how to use the glass. So it's basically we turn it on and they wear it and we turn it off.
Yeah.
And by watching the monitor, one of the challenges is, as you know, if the control area is bumped, then it may stop recording. So it's important to monitor what's going on and then run up and tap the side of the glass and make sure that. I guess I've got my glass with me right here. So this is, as we know, the control bar. And if that gets bumped during the procedure, then if it happens, you're running around taking care of a simulated patient, things get bumped. Mm-hmm. So then I just have to sort of slip in and fix it and take a time out.
Yeah, a lot of the physicians I've talked to this month, because we've had a couple of weeks of Hangouts, they like the teaching part of it, and being able to, well, I guess like you said before, they used to be able to live stream the Hangout. For people that don't understand that, it's essentially a Hangout like we're doing now, and the doctor can have a Hangout with someone remotely. The same principle, correct, Martin?
That's correct. Yes, it was actually you had to have a really good internet, and so there were problems if your internet connection was spotty. And the way I worked it was I worked it with my cell phone. So if your cell phone, so the glass went to the cell phone went to the internet. And so if you're, we happen to have some buildings in our facility that are extremely well built, so there were certain areas of that we could not broadcast from because the cell phone coverage was suboptimal because the walls were too thick. We just sort of had to figure that out. So there were obstacles, but it still worked appropriately, it worked acceptably.
You know what I found out, because I'm not an expert at Wi-Fi and internet IT, but up at the University of Indiana, where the conference is going to be, has a really strong has a strong Wi-Fi signal. I didn't know there was a difference. Some places have a strong Wi-Fi, and some places don't. Are you familiar with that at all? That was new to me, because University of Indiana has a strong Wi-Fi, and we could do Hangouts without a glitch. Up there.
That makes sense. I've not had the experience of strong and weak Wi-Fi, but it certainly makes sense.
Yeah, they had a really strong. I was surprised because I've had some Hangouts with some docs that it's kind of spotty because they're using Wi-Fi or using a cell phone or something, because all cell phones Wi-Fi, and I'll drop connections. The video quality won't be great, but up there, wow, it was just like wired. So, well, Martin, I appreciate you taking time out.
Well, I appreciate the invitation, John. Thank you very much.
Teaching in your spare time, a busman's holiday. a night off. So anything, you're not going up to the conference, correct?
Actually, I have a conflicting conference. So
Oh, okay.
the OBGYN Educator Conference is the same time, so that's why I can't make it. So
Well, hopefully you'll be able to see it. If you can't see it live, you'll be able to see it recorded. Because most of it should be recorded. If you want to catch a speaker or two, hopefully we'll have it up on the website. You can pick out the ones you like to see and watch as much as you want.
that sounds good. That sounds great.
And you can tell your students too. I'll send you the address that they can watch it if they want to watch it. But it'll be on the net or at a certain address, and I'll give you the URL. Okay, Martin, thank you very much. And anything you need, just let me know.
All right. You have a good day, John.
Thank you, Martin.
Bye.
Good luck.